All right, so this is chapter 17, respiratory system. So we're going to start off with just looking at gases first. And this is just an overview that you need to understand that gases have partial pressures to them, and the partial pressures can change with some factors such as temperature, the number of gas molecules there are, and also the volume that's given for that gas. So it follows the ideal gas law, but we're not going to work with the ideal gas law. It's just for you to understand how gases, the partial pressures of gases work and what factors contribute to their pressure. Also keep in mind that when we breathe in the air from the surrounding us, right, it's a mixed bag of gases, and each gas can exert its own partial pressure. So the total air that we're breathing in has a larger partial pressure, but it's just an additive. You just add the individual partial pressures of each gas and you get the total pressure of the atmospheric gas. So number 2 in your outline just explains that concept. And the number 3 talks about the composition of the air that we breathe. So you do want to know that the air that we breathe in is 79% nitrogen and 21% oxygen. And a very small amount of the gas that we're breathing in is going to be carbon dioxide, helium, argon, and other things. And then the quantity of water in the atmosphere that we're breathing in is also going to depend on the humidity level. And so overall, we are going to have just the partial pressure of air is going to be around 760 millimeters of mercury at sea level. And this is largely just the combination of the nitrogen, the partial pressure of nitrogen, and the partial pressure of oxygen. So that's just a really quick, just get to know gases. And then we're going to look at the solubility of gases and liquids. So this is really what we care more about, because we're looking at oxygen and carbon dioxide and their ability to move into liquids, right? So they can exist as a gas in the atmosphere, and then they're going to move into our blood, plasma, and also into our interstitial fluids that are mainly water. So if you look at number 2 for Henry's law, it just states that the solubility of a gas is going to depend on different factors. The solubility, which means how much of that gas is going to want to be absorbed in that water, in the liquid, is going to depend on the temperature. It's going to depend on the partial pressure of the gas. So the more gas you have in the atmosphere, the more will move into the liquid. And also the chemical properties of the gas. So we're looking at oxygen and carbon dioxide, and also the chemical properties of the liquid. But the liquid is always going to be water, so there's no big change there. So if you just look at this picture, we're going to compare the solubilities of oxygen and carbon dioxide. So this is looking at oxygen, and we can see that we are starting off with 100 millimeters of mercury within a finite volume, and we're letting it equilibrize. Well, I'm saying that wrong. Reach equilibrium. And after it reaches equilibrium, right, we have 100 millimeters of mercury on the outside, 100 millimeters of mercury. So same pressure. However, if you look at the concentration of oxygen in the water, it's 0.15 millimolars per liter, right? Let's look at what happens to carbon dioxide. So same scenario set up. We have reached equilibrium on the second side here, but look at the concentration of carbon dioxide in the water. We have 3 millimoles per liter. So this is compared to that 0.15 millimoles per liter of oxygen, right? The concentration of oxygen. So what this means is that carbon dioxide is much, much more soluble in water. It likes to be in water. It actually can combine with water to form carbonic acid. And so it's much more soluble than oxygen. Oxygen does not like to be in water. So you're not going to find a lot of oxygen as an oxygen molecule in water, which is why we have hemoglobin. So hemoglobin is so important because oxygen doesn't want to travel around in our plasma. Oxygen needs something to bind to be carted around and transported around in our blood. So that's the illustration here. And let's move on to look at the exchange. So keep in mind that, this is going to work just like the laws of diffusion, where if you have a higher partial pressure, the gases are going to move towards a lower partial pressure, just like a high concentration gradient those solute particles move towards a lower concentration gradient. So if we take a look at this picture here, this is actually just looking at the amounts of carbon dioxide and oxygen moving through our bodies. And don't worry about learning any of these. So I'm not going to stress this at all. There's just a fun fact here that we consume at 6 liters of air per minute. And we have, remember, alveolar ventilation, we have 4,200 mils reach our alveoli, and about 21% of that is oxygen. So we consume, if you do the math, we consume about 250 mils of oxygen per minute, and that's about 100 gallons of oxygen every day. So every day, each person's consuming 100 gallons of oxygen. So it got me to think about spacecraft, right, and space travel, and the need for oxygen if we are going to set up, a habitat on Mars, right? We're going to need a lot of oxygen. So just a fun thing to think about. But what I'm going to turn our attention to here is this picture, and that's going to be the partial pressures as we move around the body. So let's turn the page here. Okay, so one thing to keep in mind is just that the blood is going to have different pressures of both oxygen and carbon dioxide in different areas, right? And we know that in our capillary networks, we're going to have that exchange. So this is looking at our pulmonary capillaries, and then down here we have our systemic capillaries exchanging with our tissues and our pulmonary capillaries. So obviously, right, we're going to have in the atmosphere, the partial pressure of oxygen is 160 millimeters of mercury, and carbon dioxide is very low. So we have a huge pressure difference between what is in the alveoli and then what's in our bloodstream. Because in our bloodstream, if you look down here at the pulmonary arteries, right, coming into the lungs, our partial pressure is going to be 40. So we have this really big shift, this partial pressure difference of 160 in the atmosphere and then 40 in our blood. So we're going to obviously have a nice concentration gradient or pressure gradient to exchange the gas. And if you look at carbon dioxide, so the partial pressure of CO2 is about 46 in our pulmonary arteries, and in the atmosphere we have 0.3, right? So obviously, again, a nice pressure gradient where we're moving the carbon dioxide from our bloodstream out into the alveoli because we have very little carbon dioxide in the air around us. And then if you just move around, I'll point out that in your oxygenated blood, if it's fully oxygenated, your partial pressure of oxygen is 100. That's pretty easy to remember. All right, so that's going to come up a little bit later. And we can see in the cells, right? So we have, again, a nice pressure difference between what is in the systemic arteries. So if we look at the arteries with the 100, they're going to be, that oxygen is going to flow towards our cells with a partial pressure of 40. And then the carbon dioxide is going to move from our cells, 46, move into the venous blood. So not a huge pressure gradient here. We start off with 40, and then it's going to move to 46, or like 46 to 40. But carbon dioxide is very soluble, so it will move. All right, the other thing I wanted to talk about is just this word mixed venous blood. And blood in the pulmonary artery is called mixed venous blood because and generally speaking, right, these are the partial pressures of the mixed venous blood. And this is because all of our tissues are metabolizing at different rates. You might be thinking really hard on a physiology exam and your brain is working really hard, but your muscles are not. So when all of your systemic venous blood come together right before it comes into the right atrium, it's going to mix, right? All those partial pressures will mix. And so that's why it's called mixed venous blood. All right, let's see what's next. So again, just a table to show you the pressure gradients between what oxygen is working with and what carbon dioxide is working with. So you can see atmospheric air, 160, to our pulmonary arteries at 40, big pressure gradient, and then we have carbon dioxide with what is in the alveoli. All right, so this picture is showing you that diffusion across the respiratory membrane. Remember, the respiratory membrane is going to be the very thin type 1 alveolar cells right up against the capillary endothelium, very little basement membrane between them, very little liquid between them. And so our capillary network is going to cover, right, the pulmonary capillaries are going to cover our alveoli. And we can see that this is the length of the capillary. So we have a lot of length to our capillary. And we have reached, if we just look at this one here with our oxygen, we reached a maximum partial pressure of oxygen in the blood within the first third of the length of the capillary. So at 33% of our entire capillary length, we've already reached total maximum saturation with oxygen. So this is really good. This is a great mechanism because under normal conditions, even when you're exercising really hard, you're always going to have the diffusion of oxygen is always going to be sufficient. You're always going to have enough oxygen going into your bloodstream because you have basically 70% of your capillary left if there's something wrong. And that is the other point of this, is that having that extra 2/3 of capillary means that there's a safety net. So if you do have some kind of damage or liquid buildup in the lungs, such as pulmonary edema or pneumonia, and diffusion is impeded, right? Because the liquid that is building up in your alveoli, if you do have swelling in your lungs, that liquid's going to pool and create more of a diffusion barrier for the oxygen to reach the bloodstream. So this just means that you have more length to get the oxygen into your bloodstream. Under extreme conditions, it's really fatal, like pneumonia and pulmonary edema. Those are fatal. They can be fatal because it could be so severe that you're completely blocking the appropriate amount of oxygen diffusing into your bloodstream. So that's the downside. But we have this safety net of about 2/3 of the capillary network that is still present, and you can still have it pull oxygen in if there's a problem. And we can see the same thing is true for releasing the carbon dioxide. So in the alveoli, at 1/3 of the length of the capillary, we've already exchanged all the carbon dioxide with the alveolus, so we're releasing the carbon dioxide. All right, so same concept. We have a lot more room for diffusion if there is a problem. All right. So these are just some terms before we move on, and it's not like I'm going to use these terms a lot in this chapter, but it's just good to know. Hyperpnea, so the P is silent, is an increase in ventilation, like when you're exercising to meet the metabolic demands of the body. Apnea is when you temporarily stop breathing, cessation of breathing. So I think the most common, is sleep apnea. And then we have hyperventilation, hypoventilation. Hyperventilation is exceeding the metabolic demands of the body. So the difference between hyperventilation and hyperapnea or hyperpnea is that this is basically just meeting the demands of the body, and hyperventilation is going beyond the demands of the body. And hypoventilation is also underventilating, right? It's insufficient to meet the demands of the body. And then the last word that you might hear a lot is hypoxia, which is a deficiency of oxygen in your tissues. All right. All right, moving on to our next topic, which is the transportation of gases. We're looking at oxygen first. And oxygen is going to be bound and carried on hemoglobin, right? So oxygen is transported by hemoglobin because, as we said before, it's not very soluble in plasma. So when it binds to hemoglobin, it becomes, the written is Hb.O2. So that just shows you that hemoglobin has bound oxygen. So we can see the diffusion of the alveoli coming in. And then, of course, our blood cells will travel to our body and then release the oxygen off of hemoglobin and release it to our body tissues. And again, the travel, right, it's because of partial pressure differences. So we can see, right, partial pressure is 40, it's coming in at 100. Now, this is interesting. At 100 millimeters of mercury, hemoglobin is saturated. So that means that all hemoglobin and all the sites where oxygen can bind are filled with oxygen. So you can see this sort of schematic picture of hemoglobin and oxygen. And we do show that it's not 100%, but it's 98.5% saturated. So there's saturation at the level of which you're taking it away from the lungs, right? 100 millimeters of mercury. In mixed venous blood, this is the interesting thing, right? We would think that we would have a lot less oxygen bound to hemoglobin, but we don't. We actually still have 75% saturation. So that means that we only lost about 25% of the oxygen to our tissues as it's traveling around our body. And so this is going to be important. So we can see the graph here. So this is the percent of oxygen unloaded by hemoglobin tissues, right? So we're starting off with our systemic arteries at 100% saturation at 100. So this is your hemoglobin. This is your hemoglobin chart, percent saturation. And then this is your pressure of oxygen. And so at 100, right, we move up, we have nearly 100% of hemoglobin saturated. And then as we move to our veins, right, where we have 40 millimeters of mercury of oxygen, we've only lost about 25%. So why is this significant? All right, so we're going to get into this curve here. It's significant because it's really good for attaching. So hemoglobin is very good at attaching to oxygen, and it keeps oxygen at high levels in your blood. If you start to exercise and start increasing the demand, like immediately, you have to start sprinting away from something very scary, right? You have to immediately provide enough oxygen to your muscles to keep going. And so that reserve, that 75% reserve that's still on hemoglobin, right, that's there for those emergency or those quick oxygen supply when you need it, right? It's still present. So let's take a look at, and then this curve here is, so let's just stop and talk about this curve. So this is called basically the hemoglobin oxygen dissociation curve. Dissociation just means that the oxygen's coming off of hemoglobin, and it's a curved curve. It's not a straight line, because the more oxygen that binds to hemoglobin will increase its affinity for oxygen and bind more hemoglobin. So instead of seeing a straight line where it's a linear relationship with increase in oxygen, if you increase in oxygen, then you get that same amount of increase on hemoglobin. It's not that way. It's actually curved. So what this means is in the initial part of the curve, this part of the curve, that's an exponential curve. So that means that when you get a little bit more oxygen, right, that if you shift over and add a tiny bit more, that you're going to get even more oxygen added. So this little shift in the amount of oxygen present causes a greater shift in how much oxygen is on hemoglobin. So this basically says the more oxygen that binds to hemoglobin, hemoglobin gets a higher affinity for oxygen and will then bind even more hemoglobin. So kind of think of it as when hemoglobin binds oxygen, it kind of shifts the hemoglobin and makes more room. It opens it up a little bit to add more oxygen. And then you can see that it does reach kind of a plateau at the end, right? It can get saturated. All right. So let's look at the notes for a second. So saturation of hemoglobin, which is up here, right? So hemoglobin can get saturated. And yeah, so we talked about this already. So oxygen carrying capacity of blood, that arterial blood is saturated, 98.5% saturated, and then venous blood is 75% saturated. All right, so let's talk about this exercising little thing. So this really steep decline, this exponential curve, works also in the fact that it can release large amounts of oxygen when tissues need it. So we're talking about hemoglobin, right? So when you're exercising, the oxygen that's in the tissues will drop dramatically because your cells are needing it. Your cells are taking that oxygen off your blood and it's going to get rid of it right away. So the oxygen levels will drop. And so here at 20 millimeters of mercury, this is basically if you're exercising really hard. And if you look at the normal, let's just stick with the normal purple line, right? We're up here. So let's say you are right before you sort of exercise, maybe a little bit before the hardest exercise, right? We can see that if we go straight up, right? So if we shift a little bit more, when there's a little drop in oxygen concentration and the partial pressure of oxygen, there's actually a steep let go of hemoglobin. So you get a massive dump of oxygen off of hemoglobin with a little shift of the partial pressure of oxygen going down. And this is good because it's basically signaling like, hey, these cells need oxygen because we're exercising. So hemoglobin exponentially will release more oxygen because the tissues need it, right? So a small change in the partial pressure of oxygen causes a big change in how much oxygen comes off of hemoglobin because the tissues need it. All right, so looking at the outline, the exercise scenario I'm talking about is the little I, the 3 little I at the start of exercise. And then another safety benefit of this curve is that at higher altitudes, when the partial pressure of oxygen is maybe just 60 millimeters, right, 60, right? But look at the content, right, of oxygen on your hemoglobin. It's almost at saturation. There's not much difference from here at 100 to 60 because hemoglobin can remain saturated even at really high altitudes, even when the oxygen levels are thinner. So that's also a good benefit of the curve here and how hemoglobin behaves. All right, so let's take a look at the shifts that we have here. Let me quickly just get rid of my marks. Okay, so this is going to be called shifts of our hemoglobin oxygen dissociation curve, and we basically say left shift, right shift. So we can take a look at our left shift, blue line first. When hemoglobin's dissociation curve, the entire curve shifts to the left, what that means is the hemoglobin is going to increase its affinity for oxygen. Okay, so let's take a look at lower oxygen concentrations, hemoglobin still has about 80% of saturation holding on to it. Okay, so let's take a look at our dots, right? So this dot here, that's what this is talking about. So at a normal, so we have 80% saturation, right? 80% saturation of hemoglobin. At normal levels, if you had a normal dissociation curve, the purple one, we would reach 80% when we have about, 44 millimeters of mercury of oxygen, right? But if you shift the entire curve to the left, that means that we can get that same 80% saturation at a lower partial pressure. Because of that, that means that oxygen has to be holding on to, hemoglobin has to be holding on to oxygen more strongly, right? Which is the increased affinity for oxygen. And the example I have for something that shifts to the left is basically a different kind of hemoglobin. So there is a fetal kind of hemoglobin that actually does have a left shift curve. And this fetal hemoglobin has a higher affinity for oxygen, because if you think about it, if the baby's hemoglobin had the same affinity for the mother's as the mother's hemoglobin, then what's taking the oxygen off hemoglobin on the mom and giving it to the baby? So the baby's hemoglobin has a slightly higher affinity, and so it's going to take the oxygen off of the mom's hemoglobin and take it into the baby's circulation, right? So that's good. Helps the baby. And then right shift, right? So let's take a look at the right shift. So at 80% saturation, in order to reach 80% saturation on hemoglobin, you actually had to have a higher pressure of oxygen here. So at a higher pressure of oxygen, right, that means it takes more oxygen to reach that same saturation point. That means that the hemoglobin has a decreased affinity for oxygen. It doesn't really like to hold on to oxygen that much anymore, right? You need more oxygen pressure in order to get that oxygen on there. So it's basically kind of like you need more oxygen present to kind of force it on hemoglobin just a little bit. So this is called a right shift. A right shift is going to decrease the affinity for oxygen. And there's lots of examples for right shift. So right shift would mean that factors that affect right shifting is going to be an increase in CO2, a low pH, and an increase in temperature. So right shift is going to be carbon dioxide, acid, low pH, and then temperature, high temperature. And what do these look like? These look like really active cells, right? Metabolically active. Okay. So when you're exercising, that great example of exercising, your cells are working hard. They are pumping out CO2. They are producing acids, lactic acid, keto acid, and your temperature is going to go up. And so all of these factors will cause hemoglobin, the curve here, to shift to the right and to release its oxygen, because the cells are crying out for oxygen, right? So it's going to release the oxygen, and it's going to do that because it has a decreased affinity for oxygen now. All right, so these are some other, so when you turn the page, there's other factors affecting hemoglobin's affinity for oxygen. So I listed the three we just talked about. Temperature, right? As metabolism rises, here's temperature, it's going to do a right shift, right? So you can see at a higher temperature, we have a decreased affinity. And at a lower temperature, we have an increased affinity. So the decreased affinity is good. It's going to release oxygen to those active cells, right? Another one is pH. So pH, same concept. When you have a small decrease in pH, because we're creating carbon dioxide, which is going to act like an acid, it's going to tell, basically you evolved this method where it's going to release the oxygen. So that's that. And that's actually called the Bohr effect. So when, so the acidic environment is going to drive the release of oxygen. And so as hemoglobin binds oxygen, some of those amino acids are going to release the hydrogen ions. That's going to drive down the pH, and it's going to shift it to the right. So what this means is when you have more oxygen binding to hemoglobin, the oxygen binding itself, when hemoglobin's saturated, it can actually then help release the oxygen, right? Because it doesn't work, your body won't work if the hemoglobin is saturated and the hemoglobin still has this really high affinity for oxygen. It's harder to let go of oxygen. So when the Bohr effect says as hemoglobin binds oxygen, some of those amino acids will release hydrogen ions that drive down the pH, and then that pH will shift it right. So it'll loosen up the oxygen when it's saturated. Okay. And then the carbon dioxide we talked about. So that's actually called the carbamino effect, and I don't have a picture for that, but carbon dioxide actually binds to hemoglobin. So we can just draw the 4 subunits of hemoglobin here, right? So CO2 actually does bind to hemoglobin, and it's called carbaminohemoglobin. So carbaminohemoglobin becomes HbCO2. And that actually, the attachment of this carbaminohemoglobin is going to change the conformation of hemoglobin and causes it to release oxygen. So you can kind of think of it as carbon dioxide and oxygen are kind of fighting for spots on hemoglobin, because when carbon dioxide binds, it actually pushes off oxygen. And the same thing is opposite. So when oxygen comes in, it actually pushes off the carbon dioxide. Something else that I don't have a picture of, but it is in your notes, it's a molecule called 2,3-biphosphoglycerate, and this is just known as 2,3-BPG. And this is a byproduct of glycolysis inside red blood cells. I can just kind of do that, right? So the red blood cells will actually produce this 2,3-BPG when oxygen levels are low. So low oxygen levels will create some 2,3-BPG. So these are going to go up. Now what that does is it inhibits, it's going to decrease. So this is going to decrease the affinity for oxygen, and it's going to release oxygen. Okay, so at low concentrations, that makes sense, because if there's low concentrations of oxygen, that means that the environment needs oxygen. So the hemoglobin is going to release the oxygen to the environment. And then carbon monoxide. So CO, carbon monoxide, we've all heard of carbon monoxide poisoning. And this one actually has a very high affinity for hemoglobin. And so it takes up all those spots where oxygen would bind to, and it stops the oxygen from binding to hemoglobin. So if you're in an environment with lots of carbon monoxide, the hemoglobin, right, is not going to bind to oxygen anymore. So your cells won't get oxygen, and that's lethal. So carbon monoxide poisoning causes asphyxiation. And technically, asphyxiation is a condition where you don't have enough oxygen in the body. And that can be caused by suffocating. So if you stopped breathing, something blocked your airway, that is a kind of asphyxiation. But you can also have that ventilation, like people who have carbon monoxide poisoning are breathing, right? They can inhale and exhale, but they just cannot carry that oxygen in their blood. All right, so let's do some review questions. If a tissue were to create an excess amount of CO2, this would. So the answer should be A, right shift. Under normal resting conditions, the percentage of oxygen that's unloaded from hemoglobin in arterial blood is. All right, so arterial blood will unload about 25% of its oxygen to the tissues, and then that means that venous blood still has 75% saturation. The hemoglobin is still 75% saturated in venous blood. At higher altitudes, let's take a look and see if you can find the right answer. Answer should be C. All right, so I'm going to pause this now and do part 2, carbon dioxide.